To chair the next session, may I invite Dr. S.S. Sharma. Dr. Sharma, could you please put your video on, please? Camera on. Dr. S.S. Sharma recently retired as a senior professor and head of the Department of Gastroenterology at the SMS Medical College, one of the largest medical college hospitals, not only in the state of Rajasthan, but I think in the country, with huge patient load. And he's one of the senior gastroenterologists of the state of Rajasthan. So he's going to chair the presentation by Dr. Saraswat on endoscopic management of chronic pancreatitis. Over to you, Dr. Sharma, please.
Good evening. I think endoscopic management of the chronic pancreatitis is the most important cornerstone treatment for the pain as well as the various complications of the chronic pancreatitis. And Dr. Saraswat, with a vast experience of endoscopy, I think is the most suitable speaker for this topic. I invite Dr. Saraswat to speak on this.
Yeah, just to interrupt, Dr. Saraswat was my colleague for more than 3 decades at SCPGI, and now we are colleagues at the Mahatma Gandhi Medical College Hospital. He is the chief of hepatology at our new institution, and he has done a great service in establishing a liver transplant program at the Mahatma Gandhi Medical College Hospital. Dr. Saraswat, please.
I'll share my screen.
Yeah.
Thank you very much for those very kind words, Vinay and SS. So I will try and cover the area of endotherapy for chronic pancreatitis in the next 15 minutes. As Matthew felt, so do I, that time allotted and the topics to be covered, there is a disproportion. But nevertheless, to move on. What are the situations in patients with chronic pancreatitis where endotherapy may be required? The first and foremost, the indication is pain management. And pain in these patients is generally related to pancreatic ductal hypertension based on pancreatic duct obstruction, which may be due to calculi, due to pancreatic strictures, or both calculi and strictures in the same patient. Local complications may arise, like the development of a pseudocyst or an inflammatory mass, or even a tumor in the head of the pancreas, which can result in pain. Biliary obstruction, interestingly, also has been associated with pancreatic type pain, and relieving this obstruction may go a long way in alleviating pain in some patients. And finally, particularly in those who abuse alcohol, retroperitoneal nerve involvement that Matthew touched upon briefly could be a factor that is contributing, and each one of these is amenable to endoscopic management. Then biliary tract obstruction due to strictures at the lower end of the bile duct, which may be benign strictures there, or maybe large calculi in the head causing obstruction, development of a tumor. And in rare instances, we have seen patients who develop portal vein thrombosis as a local complication of pancreatitis, develop a portal cavernoma, and can develop biliary obstruction, which requires treatment in its own right. Then another complication of chronic pancreatitis is the development of pancreatic pseudocysts, which can be drained, used to be drained earlier with plastic stents. Now, US-guided drainage with the placement of expandable metal stent or lumen-opposing stents has come in, particularly if there is a walled-off necrosis, which can happen when there's an acute exacerbation in a patient with chronic pancreatitis. And of course, there could be external pancreatic fistulae or internal fistulae due to pancreatic, resulting in pancreatic ascites, pancreatic pleural effusions, all of which are amenable to endotherapy. GI bleeding, well, that does come under the purview of the endoscopist due to gastric or esophageal variceal bleeding. Rarely, you also have hemosuccus pancreaticus in acute exacerbations, more often in acute pancreatitis, where the endoscopist has more of a diagnostic rather than an interventional role, except, as my colleague Dr. Praveer Rai has shown from SGPGI, can splenic artery aneurysms or the others can be some aneurysms that cause bleeding can be injected by EUS-guided glue injections in these people. Now, as you can see, the extent and the requirement, the final thing is, at times when you use plastic stents, they migrate, and the endoscopist, its onus is on him to retrieve these when they have migrated. So the gamut, the spectrum of endoscopic interventions in CP is indeed huge, and I'll try and cover only the aspects of pain management to some extent in the limited time available to me. Now, as we all know, pain in chronic pancreatitis is due to intraductal hypertension, and surgical as well as endoscopic interventions that decrease intrapancreatic pressure result in the relief of pain. Other factors that are shown here may also contribute in some patients, and particularly those who have alcohol-related chronic pancreatitis. In many of our patients, and in fact, my largest experience has been with the idiopathic chronic pancreatitis in our country, where elevated intraductal pressure seems to be the dominant mechanism contributing to pain, which, as we have talked about, could be calculi, stricture, or the combination, as Dr. Reddy had reported way back 20 years ago, and that is borne out in the subsequent large works that he and Dr. Manu Tandon have published from the Asian Institute of Gastroenterology. We have various options. I left out the medical options. They are there because Smith Matthew has covered them. For pain management in chronic pancreatitis, where calculi are causing obstruction, you have the options of extracorporeal shockwave lithotripsy with or without ERCP. We've already discussed celiac plexus blockage and its limited role in the question answer session earlier. And of course, a major mainstay historically and currently in many patients would continue to be surgical drainage of the main pancreatic duct, which will be covered in the subsequent sessions. I'll spend some time in talking to you about extracorporeal shockwave lithotripsy and endotherapy. The patients who need it, one can look at this diagram and see that when the calculus is obstructing the main pancreatic duct and is producing downstream hypertension, the pain becomes significant, and this intraparenchymal pressure is also increased. And as you can see in this pancreatogram, some stones in the head, and particularly this at the genu that is causing obstruction, needs to be tackled to relieve pain. And only occasionally does standard endotherapy using sphincterotomy, Dormia extraction actually work. Situations in which following lithotripsy or otherwise you might have an impacted stone in the papilla causing pain could be tackled by standard approaches that one used for bile duct stones, that is balloon extraction as shown here. But by and large, most stones in chronic pancreatitis are quite large, lumino-occluding. They are adherent to the wall. It's difficult to get a basket beyond them, and endotherapy, standard endotherapy, does not work. These patients are candidates for extracorporeal shockwave lithotripsy. Indeed, the guideline is that a single radio-opaque calculus more than 5 millimeters or 3 or more calculi of less than 5 millimeters should be treated by ESWL rather than standard endotherapy. The strategies used is lithotripsy, which may be and followed by spontaneous expulsion and expectant management in a minority of patients that I'll come to later, or ESWL followed by ERCP to clear the fragments. And the timing of ERCP, some people would want to actually do a sphincterotomy before they undertake lithotripsy, because after lithotripsy, the edema, the petechiae in the mucosa may pose difficulty in cannulation. But most people would do endotherapy after the rounds of ESWL, and whether it should be early, intermediate, or delayed, there is a variation in the literature. But delayed generally results in better success rates of almost up to 90% in terms of clearance of fragments. Now, lithotripsy, the shockwave generators could be electrohydraulic, electromagnetic, or piezoceramic by these manufacturers. Basically, shock waves are generated in the degassed water by for example, in the electrohydraulic using a spark gap electrode. And these shock waves are then focused by an acoustic lens on the target, which is the calculus within the body, be it renal or pancreatic. And these shock waves are guided into the body by a water cushion, which is apposed closely to the skin of the patient who's being undertreated. The energy levels vary, and this is 0.54 millijoules per square millimeters would correlate with the highest energy level of 6. This is for the Dornier machine. Generally, 3,000 to 5,000 shock waves are administered under conscious sedation, but more often, especially if endotherapy is to follow, under anesthesia and the general anesthesia. And the mean number of sessions using these shock waves have ranged in reports from 1.3 to 6 sessions. So this is a patient being focused for ESWL, which are calculi being visualized by fluoroscopy, which is preferred, and particularly bimodal fluoroscopy, so that you can actually target it very accurately. rather than ultrasonography. And generally, the most proximal calculus near the head, in the head of the pancreas, near the papilla, is first focused and fragmented, and then one can go down the duct, and multiple sessions may be needed if there is a heavy stone burden. Now, coming to the results of pancreatic lithotripsy in the early years, this is a summary of about 17 series that were published between 92 to 2013, over 3,000 patients. Over 1,000 of them were published by Manu Tandon from AIG, over 1,006. They reported a combined fragmentation rate of about 87.5%, and complete clearance rate of 60% was the median clearance, ranging from about 40 to 75%. And the most recent updated series from AIG has gone up to over 5,000 patients with a 90% successful fragmentation and over 72.6% complete clearance of calculi. The success of ESWL with or without ERCP is in successful fragmentation being achieved, as well as relief of obstruction, all of which is objectively documented by X-rays and imaging. Decrease in radiographic density of the stone can be visualized once it fragments and gets pulverized. The stone surface area increases, and the heterogeneity and a powder-like material in the side branches can often be visualized on plain X-ray. Reduction in pain, decrease in main pancreatic duct diameter, and easy deep MPD cannulation would signify relief of obstruction. Predictors of successful clearance is the presence of single large stones, which form the large bulk of even I think over half the patients from the AIG experience. Absence of a main pancreatic ductal stricture gives you better successful clearance, and calculi with low radio opacity, less than 1,000 Hounsfield units. For example, you often see filling defects which are radiolucent. They, of course, are very easily extracted and may not require fragmentation with ESWL. Some patients will recur 1/3 over 77 months of follow-up, and this is when there is a main pancreatic duct stricture or incomplete stone clearance. Continued pain despite successful treatment of the calculi could be, as I think Matthew has pointed out, if the patient continues to smoke, continues to abuse alcohol, when the likelihood of development of diabetes dramatically increases, and when there's a prolonged duration of pre-existing disease. Now, does endotherapy like this and clearing the duct, does it improve exocrine or endocrine function? Well, the answer is a mixed maybe. And what has been seen is in exocrine function, if you were to resort to relatively early treatment within 3 years of onset of painful chronic pancreatitis, rather than years or decades later, steatorrhea progression may be delayed so that you may hold the disease rather than regress it. And this may be for as long as 10 years before de novo steatorrhea in these patients appears. And similarly, it may reduce the risk of de novo diabetes mellitus. Complications, no mortality reported with this in the various studies and trials reported. And less than 7% have major complications like post-ESWL pancreatitis, bleeding, infections, stone fragment impaction, or perforation. And acute pancreatitis you can prophylax with the use of rectal indomethacin, as one does routinely in most forms. I'll quickly take you through a few pictures.
Three more minutes, please.
Yeah, so I'll take you through a few pictures for clearance of stones. So if there is a dominant stricture, as is shown here, balloon dilatation with a hurricane balloon positioned within the stricture, and after one or usually many sessions, you may achieve clearance of this duct. Often stents are required for this. And this shows a bundle of stents placed in the pancreatic duct for keeping the stent open for variable periods. If stents migrate, microdormia baskets can be used to remove them. This is a patient with incomplete pancreas divisum in whom a 12-year-old boy with recurrent pain, when a guide wire cannulation from the main papilla was done, this very funny contour of the wire was noted, which was explained when dye was injected and you had a massively dilated dorsal pancreatic duct with multiple calculi that seemed to be joining the ventral duct close to the point of the major papilla. And upstream, you can see the duct to the body and tail. With dormia and balloon extraction, the stones could be cleared after a good sphincterotomy at the major papilla, and then the anatomy became clearer. Dorsal ventral union happening here, the duct joining the dorsal duct and the body and tail. And as we did balloon occlusions and swept, we could appreciate that this was incomplete because the dorsal duct collapsed and a more normal contour ensued. The ventral duct, ventral duct is seen here, and the pancreas divisum, the upstream, the dorsal duct is visualized. Another young man who had intractable pain and significant weight loss, when we attempted treatment at the major papilla while the bile duct would be cannulated, at the main dorsal duct across the spine, we couldn't enter, although the uncinate duct was repeatedly cannulated. Possibly radiolucent calculi were obstructing. So we attempted cannulation at the minor papilla, which was unfortunately successful. And a markedly dorsal duct, dilated dorsal duct with a radiolucent filling defect was seen. And between the ductal dilatation and the minor papilla, a long, narrow stricture could be seen, which was then treated with balloon dilatation. And you can see a prominent waist on the hurricane balloon, which could be inflated and abolished at this time. And subsequent follow-up after the first session, here are the endoscopic pictures: major papilla, minor papilla, attempting cannulation, sphincterotomy, and failing to get into the dorsal duct. So trying the minor papilla, where we could do a sphincterotomy and dilate the minor papilla with a balloon, following which the initial stent was placed, and which was a very tortuous course here and a tight stricture, but could be straightened out later. This patient required 4 sessions totally of endotherapy spread out. Once he was pain relief, he wouldn't turn up. And here you can see the stricture appears to have become more pliable, although it persisted when the stent was removed. And we could put in 2 10 French and 1 7 French stent in the second session, which could go up to 4 stents, 3 10 French and 1 7 French in September. And in April 2023, roughly a year after we started, 15 months after we started, we had no significant waste on the balloon, and no stricture could be noted. And now the patient is pain-free, gaining weight, and off stents for the last several months. Pancreas divisum, resulting in chronic pancreatitis. I think I'll run through this fast. Major papilla didn't really show us, we allow us to enter the dorsal duct. So despite adequate attempts at the major papilla, we were sure of the minor of the divisum anatomy suspected on the MRCP, and minor papilla cannulation could be achieved, from which we could opacify the dorsal duct. Apologize for the poor quality of the video. And we could see the duct till the tail that we could be seen. And then minor papilla sphincterotomy could be carried out, followed by the placement of stents and balloon sweeps to clear the dorsal duct. That's a stent going in. And I think I'll skip this. This is a migrated stent that was removed.
We'll take the questions now. Dr. Sharma, please.
I think I'll give me 2 minutes to go through the guidelines, which is important for at least give you an overview of what has to be done. The European Society of Gastrointestinal Endoscopy has made certain recommendations in 2019. ESWL as the first line therapy for painful, uncomplicated chronic pancreatitis with an obstructed main pancreatic duct. ESWL, ERCP to be added in case there are incomplete clearance, and the size of stones I had mentioned is re-emphasized here. Factors that predict the good outcome and thus should guide us in endotherapy are listed here, and I covered some of these in my presentation. Stenting to treat the strictures is recommended, but most of us follow multiple side-by-side plastic stents rather than surgical therapy. No place for enzyme therapy. Antioxidants can be used for these therapy, as the ECG says. And surgical therapy is recommended in case first-line approaches like endoscopic and pancreatic drainage have been exhausted or are unsuccessful in relieving pain. Thank you very much for your attention.
Dr. Sharma.
Hello.
Yes, sir. Please.
Thanks, Dr. Sarsu, for a very simplified presentation of the management of chronic endoscopic management of chronic pancreatitis. The questions, where are the questions? I don't see any questions.
In the chat box. So there was a question which was asked earlier by Dr. Jayapal Reddy. Dr. Saraswat, maybe you can take that at 7:38 p.m. because you touched on pancreas divisum. So you can take that question 7:38 p.m. Dr. Jayapal Reddy.
In the chat box, is it?
Yes. I will read it out. Young patient, type 3 pancreas divisum on MRCP, multiple stones in the uncinate alone. Rest of the pancreas is healthy on CAT scan with acute episodes once in 3 months, no diabetes, no malabsorption. What should be offered?
See, if there is significant pain, as you're saying, there is pain, he needs pancreatic ductal drainage. These uncinate process calculi are not responsible for the pain. And I guess drainage of the rest of the duct through the minor papilla, as I've shown in a couple of the patients that were discussed earlier, would be a good way to treat this patient. And in case pain still persists after ductal decompression while minor papilla sphincterotomy has been achieved, I guess then you could resort to extracorporeal shockwave lithotripsy to clear the uncinate process. I, in my own experience, have had a few patients like these. And once the dorsal duct that drained, that's the bulk of the gland is drained through the dorsal minor papilla, they are usually pain-free and may not need much attention to the calculi lying in the uncinate.
There is another question, the last one by Dr. Jayapal again. Maybe you can take that in the chat.
Practical case scenarios is that should in CP, which should proceed to surgery upfront without considering any form of endotherapy. How to complete multiple complications with a one-time solution by surgery. Well, I think the patients, a single large calculus obstructing, causing pain, they should be endotherapy, especially with ESWL, works very well. The direct surgery would be if there's a very heavy stone burden and the entire duct is packed, and it would take multiple sessions. I remember one patient who's insisted on not undergoing surgery. We had to do almost 5 or 6 sessions of ESW at Lucknow before we could clear the duct that was lined with stones from head to tail. That means a certain cost, and only in patients who are unfit for surgery or refuse surgery would one do endotherapy in this case. So these would be some situations where one could consider directly treating them with surgery. Now, one time vis-a-vis repeated attempts, I think that is a call that is the equation needs to be offered to the patient, the cost, the benefits, the versatility of ERCP. You come in, you go out the next day, you spend very little time in hospital and recovery time and have relief. The multiple sessions are required in case a stricture has to be treated. If you have the 30% patients that are presenting with strictures will need reiterative treatment to tackle the stricture. The others, a single time one or maybe at the most 2 sessions of endotherapy would suffice in clearing the stone burden and rendering the patient pain-free. Hope that answers you, Kamalji.
Yeah, there was another question at 7:49.
Okay. A 36-year-old male, history of alcohol, CCP with a large single stone in the head of the pancreas, attempted ERCP failed, developed acute and chronic pancreatitis with bilateral pancreatopleural fistula, managed conservatively with ICD. CCT showed portal vein thrombosis with cavernoma. Can you add some more complications, please? Almost 10 months, asymptomatic and PERT on Buscopan, stone still there. No fistula tract is seen on MRCP, no varices. When should we intervene? Well, the patient will tell you when to intervene. If the patient is pain-free and not requiring pain, for some reason the stones are disimpacted, it is usually challenging scenario for the endoscopist, for the surgeon to attempt anything in this patient. The surgeon will probably have to do a shunt if a vein is available before attempting to go anywhere near the pancreas in this patient. If this patient were to have repeated recurrence of pain forcing you to intervene beyond PERT, ESWL is out. In patients with cavernomas and vessels in this region, you cannot use shock waves. So you are left with the standard endotherapy, and whether that will or will not relieve by pancreatic drainage or attempting fragmentation. At Lucknow, we have had experience of managing patients without ESWL because the machine broke down the last couple of years and we couldn't get a new machine. So if one is persevering enough and the patient demands it and it needs it, you are able to actually, with multiple sessions and mechanical means, fragment some stones. Now there are reports of laser lithotripsy of pancreatic duct calculi when you go through the main pancreatic duct and use laser holmium laser to fragment these stones, which could be attempted in these very difficult situations. Otherwise, you are back to stenting or bridging the stone, draining the gland, and keeping the patient on stents. Hope.
For the audience, I'll read a comment by Dr. H. Ramesh that if you see stones in the uncinate process, it could be a red herring to indicate an underlying pancreas divisum. So look for it. There is a question by Dr. Vijay Bada. Maybe you can take that, 758.
Right. Is there a cutoff on the number of PD stent exchanges? When do we declare completion of treatment by endotherapy? Now, I think endotherapy is complete once there is no you are able to show that the stricture has gone or is negligible and is not causing obstruction. I think I showed in one of the slides that there should be relief of pain. There should be free pancreatic drainage, and a deep cannulation of the pancreatic duct should be possible, which would mean that there is adequate access and drainage of the gland happening when we call it. And most patients are treated with up to 3 to 4 stent exchanges until you achieve a near normal caliber. In my own experience, when we put in these stents and you place a stent bundle, the number of stents decides how long you have to keep it in. If you're going to keep a single stent in and out, you can continue doing it indefinitely without influencing the stricture too much. So I tend to place multiple stents if the ductal anatomy will permit, so that the stricture gets remodeled and you have a reasonable diameter of the duct, because as we all know, the normal duct in the head, 5 millimeter, does a good job of drainage. And in a dilated system without calculi obstructing, the drainage will be satisfactory. You do not really need to go beyond that diameter for achieving drainage, and 2 to 3 sessions of stent exchanges should suffice.
There is a complication presentation.
Yeah, complications with
lamps.
Yeah, we didn't cover lamps here. Lamps is only would be for walled-off pancreatic necrosis, or maybe pseudocyst, which has a large amount of solid or debris in there. Now, the problem with lamps is that it is an expandable metal stent that expands and compresses the wall of the tissue. And there have been reports with lamps left beyond 4 to 6 weeks in which at removal, there can be bleeding due to vessel being eroded in the wall because of the lamps is exerting constant high pressure. So that is a major concern. And now most people who place lamps for even WON would like to remove it by about 4 to 6 weeks after it has been placed. Incidence of gastric fistula, I am not sure I've seen any gastric fistula. Yes, large collections eroding into the stomach and creating a fistula with the retroperitoneum. These have been reported and noted more often in the duodenum, but occasionally in the antrum. But as part of treatment of pancreatitis, I don't recall seeing any. If there's a large gastric fistula, which is symptomatic, people have now placed Ovesco clips over the scope, large clips, which for bowel perforation, for a gastric leak, for any esophageal perforations, are in the hands of the experts who place it properly, are very effective in closing many holes in the GI tract at different locations.
Dr. Sharma,
Yes.
last minute comments.
Yes. Thanks, Dr. Saraswat, for highlighting the importance of endoscopy in management of pain in chronic pancreatitis. But one question should be there, that any patient with recurrent pain of pancreatitis without significant dilatation of the duct, one should not attempt endoscopic management, because such patients are less likely to benefit from the endotherapy. So there should be significant dilatation of the duct. Many people are attempting without dilatation, producing complications. So that should be very clear that there should be dilatation of the duct.
You have to demonstrate obstruction of the main duct for before therapy. Thanks for bringing that up, Dr. Sharma.
Thank you. Thank you, Dr. Sharma. Thank you, Dr. Saraswat.